Welcome back to Cardiovascular Lecture number 14. This is part 2. And in this short video, we're going to consider the supply of blood to the heart, the coronary circulation, and the demand for blood flow, the workload of the myocardium. The heart is nourished by two main arteries, the left main and the right coronary. They are the first to branch off the aorta, just beyond the cusp of the aortic valve. So the heart is very self-serving. The first organ that it feeds is itself. The right coronary artery, the RCA, supplies mainly the right heart, the right atrium, and the so-called inferior walls of the right ventricle. The left main artery feeds the left atrium and the harder working left ventricle, but there is some overlap and inter-individual variability. The left main branches into the left anterior descending, or the LAD. The LAD feeds the septum and the anterior walls. The other branch is the circumflex artery, which wraps around the backside of the heart to feed the far lateral walls. The three most common sites of coronary obstruction, infarction, are first, the left anterior descending, second, the right coronary artery, and third, the circumflex. The left main is sometimes called the widowmaker because significant obstruction of this artery deprives large regions of the hard-working left ventricle of adequate blood flow with grave consequences. I have included this slide to illustrate that each of the three vessels feeds a different territory of the heart. You will need to know these territories next year in Block 7, Cardiology, but not now. This slide shows a cross-section of the wall of the ventricle. The large coronary arteries travel along the surface of the heart. They are shown here in red. These coronary arteries penetrate inward through the myocardium, and these vessels progressively bifurcate as they weave into the endocardium. It's important to note that capillary density increases tremendously in the endocardium. Why might it be especially important for the endocardium to be perfused with a greater number of capillaries? Well, we will see in a moment that extravascular compression of the coronary vessels during ventricular contraction impedes blood flow to the endocardium to a greater degree than to the epicardium. This image on the right shows a casting of the coronary vessels made by injecting red latex into the aorta and coronary arteries. Capillary density in the heart is very high. It's tenfold greater than in skeletal muscle, especially in the endocardium. In both types of muscle, each fiber is on average adjacent to 4 capillaries. But the cardiac myocytes are so much more slender that the capillary density is almost tenfold higher. So this allows for very short diffusion distances between the incoming blood and the hungry myocytes. Another difference illustrated here is that in skeletal muscle at rest, only a small proportion of the capillaries are perfused at any given time, whereas in the cardiac muscle, a higher proportion of capillaries are perfused continuously because, recall, the heart is really never given an opportunity to rest. The heart extracts more oxygen from the incoming blood, even at rest, than any other major tissue in the body. At rest, approximately 70% of the oxygen in blood is extracted as the blood flows through the coronary capillaries, as compared to only 25% for other body tissues. Now, during exercise, when the heart is called upon to pump faster with greater vigor, the heart's need for blood flow may increase 5-fold. But since oxygen extraction from the blood is maximal, even in the resting heart, any increase in the need for oxygen and fatty acids must be met by an increase in blood flow. We're going to see how that happens momentarily. So greater O2 demand must be met by an increased blood delivery. The heart also has the highest rate of oxygen consumption per mass of all organs in the body. The resting coronary blood flow of the whole heart is about 140 mils per minute per 100 grams of tissue, and that represents about 5% of the cardiac output. As you would predict, the highest oxygen consumption is seen in the harder working left ventricle, and the least hard-working atria have the lowest MDO2. When oxygen demand outstrips supply, the result is ischemia. The coronary circulation has evolved to meet several challenges. First of all, as we mentioned, the heart's demand for ATP energy is high and continuous. Second, metabolism is preferentially aerobic through beta oxidation of fatty acids, and this requires a lot of O2. And third, as we will see, coronary flow is suspended during systole by extravascular compression. The heart is an oxygen hog. Its oxygen extraction from the blood is extremely high, and the heart is a blood hog. It receives 5% of the cardiac output, yet it constitutes less than 0.5% of the body weight. So in exercise, as the heart's MVO2 increases up to 5-fold, how does blood flow delivery increase in proportion? Remember the phenomena of active hyperemia. As the heart works harder and consumes more oxygen, coronary blood flow rises to meet that demand. And this occurs in large measure through a reduction in coronary vascular resistance. Local metabolites play a big role in this, particularly hypoxia and the ATP breakdown product adenosine. Nitric oxide, released by the vascular endothelium, appears to play an important role in coronary vasodilation. What if the coronary arteries are obstructed and just cannot deliver enough oxygen and fatty acids to meet the metabolic demands of the hard-working heart? When these oxygen demands reach a certain critical threshold at which the coronaries cannot deliver enough blood flow, then the downstream regions will experience ischemia. Suppose there is an obstruction of the left anterior descending that cuts off most blood flow. There will be a downstream zone of infarction in which the cells are dead. Surrounding this zone of infarction will be a zone of injury where cell function is irreversibly impaired even if blood flow is restored. And surrounding that zone of injury will be a zone of ischemia. In ischemia, the cells cannot operate at this elevated workload without accumulating an energy debt, with cell function reversibly impaired. So if blood flow is restored to the zone of ischemia, the cells will regain most of their function. It's important to recognize that this ischemia occurs in spite of maximal local coronary vasodilation. The coronary vasodilation is just insufficient given the upstream obstruction. So normal functioning of the myocardium requires a near perfect match between metabolic demand and nutrient supply. The supply side depends on blood flow and on the blood oxygen content. If oxygenation of blood by the lungs is impaired, for example in chronic obstructive pulmonary disease or in congestive heart failure, or when ambient O2 tension is low at high altitude, for example, or when the blood is deficient in erythrocytes. The demand side reflects the workload of the heart. Remember that the cardiac minute work is proportional to the pressure work times the volume work times the heart rate. The pressure component will depend on the afterload, the arterial pressure. The volume work will depend on the preload, the end diastolic volume. Increases in the vigor of pumping, the contractility of the ventricle, will increase MVO2 demand. And contractility, along with heart rate, will depend on sympathetic drive. An increase in wall tension will increase the workload, the MVO2 demand of the heart. And this will depend in large measure on the law of Laplace. An important feature of coronary blood flow is that it is phasic. Think about the pressure gradient that drives blood flow from the large coronary arteries that run along the surface of the heart and project into the endocardial capillaries. That pressure gradient, the delta P, will equal the arterial pressure minus the pressure in the ventricle. Because as the ventricle contracts and squeezes down on the blood, the pressure within the ventricle rises to match the arterial pressure at the moment the aortic valve opens up. That's illustrated here. We see the arterial pressure tracing with the dichrotic notch oscillating between 120 systolic and 70 diastolic. The blue line superimposes the pressure in the ventricles. During systole, when the ventricle contracts and the pressure within the ventricle rises, that pressure pushes against and squeezes the blood vessels that run through the wall of the ventricle. And this extravascular compression is especially severe in the endocardial layer than in the epicardial layer. Recall that this resistance to flow during systole in the endocardium is partially offset by the greater density of capillaries there. Even so, the endocardium is more susceptible to ischemia and coronary artery disease. So why is coronary blood flow phasic? To illustrate that, let's consider the so-called coronary perfusion pressure. The coronary perfusion pressure is this delta P here. The the difference between the pressure in the aorta and in the left ventricle. Aortic pressure varies between 120 and 70, and left ventricular pressure varies between 120 and 0, as shown here. So this pressure gradient, shaded in green, is the driving force for blood flow to the endocardium, and it is near 0 in systole and maximal in diastole. So the left ventricle receives most of its nourishment during diastole, and unlike every other organ in the body, blood flow to the heart decreases during systole and returns during diastole. Think about what happens in exercise when the heart is called upon to beat faster and more vigorously. As the heart rate increases, diastole shortens, so the flow of blood to the left ventricle is curtailed even more when the heart beats faster, despite the fact that it needs more nourishment when beating faster. We have modeled the phasic nature of coronary blood flow in the left heart, but blood flow to the right ventricle is also phasic. But vascular compression during systole is not nearly severe on the right side of the heart, which operates at pressures that are 1/5 those on the left side. So to recap, the contracting heart compresses its own blood supply, extravascular compression. The left ventricle receives 80% of its coronary flow during diastole. Coronary flow to the left ventricle can even stop during systole, and the resulting energy debt accumulated during systole can be repaid during diastole by the phenomena of reactive hyperemia. This extravascular compression is much greater in the left ventricle than in the right, which has far lower pressures. This graph reiterates what we just talked about with the challenges of tachycardia. In tachycardia, there is more frequent coronary vascular compression and less time spent in diastole to provide for coronary flow. So there is a decrease in the supply, while at the same time there is an increase in demand due to the increased workload. Here's another summary slide. The MVO2 will increase as the heart beats faster, as the ventricles pump with greater vigor, and if they are called to eject against an afterload pressure. And remember, pressure work is energetically expensive. The MVO2 will also increase, but not as much, if the heart is called upon to pump greater volume. This table illustrates that quantitatively. If heart rate is increased 50% over resting, the MVO2 will increase by 50%. Makes sense. If ventricular inotropy, contractility, is increased 50%, the MVO2 will increase by 45%. A 50% increase in volume work is not that energetically expensive, only a 4% increase in MVO2. But pressure work is far more expensive. Suppose your patient has long-standing arteriosclerosis, coronary artery disease. His narrow coronary vessels may have a difficult time increasing the delivery of blood to meet these increases in metabolic demands. What could you do to reduce the workload of your patient's heart and bring a better balance between coronary supply and metabolic demand? Suppose this poor donkey requires a full bucket of oats every day in order to stay healthy enough to pull this load. But his cruel master is only able to give him 1/3 of a bucket of oats every day. The donkey is going to get sicker and sicker and less able to do work. Maybe we can't give the poor donkey more oats, but we can lighten his load and reduce the number of calories that he burns every day. This is the therapeutic approach for a patient with ischemic heart disease. Lighten the load, and the donkey will feel better and be able to perform more work. One way we can do that is with drugs. The cornerstone therapy for ischemic heart disease involves 3 drugs: beta-1 blockers, diuretics, and vasodilators. How do they work? If we give our patient a beta blocker like atenolol, we will reduce the contractility, the vigor of pumping, and the heart rate, and the workload of the ventricle will decrease, as will the MVO2 demand. If we give our patients a diuretic, the loop diuretic furosemide will increase urine output by the kidney, and that will unload the venous reservoir and decrease preload. The decrease in preload will in turn reduce stroke volume, so there will be some reduction in cardiac output and arterial pressure after load. Finally, if we give our patient an ACE inhibitors like lisinopril, we will interfere with the renin-angiotensin-aldosterone cascade, and as we lower the plasma levels of angiotensin II, a potent vasoconstrictor, the vasodilation will reduce the systemic vascular resistance and arterial pressure will decline, and dilation of the veins will decrease preload, decrease cardiac output, and contribute to a lowering of blood pressure and afterload. I wanted to quickly introduce the term coronary flow reserve. In health, autoregulation of the coronary vessels and metabolic vasodilators can increase coronary flow 3 to 4-fold to meet demands such as exercise. And in large measure, this reflects local vasodilator control by the metabolite adenosine. This capacity to increase flow is called coronary flow reserve. And in patients with atherosclerosis, coronary artery disease, coronary flow reserve can be low or non-existent. Coronary flow reserve can be measured in the catheterization lab. A catheter is threaded up into the coronary artery and it has a Doppler flow transducer and sensor on its tip. This allows for the measurement of the linear velocity of blood flow. Blood flow velocity is first measured under baseline conditions. You see that coronary blood flow is phasic with each cardiac cycle. Based on our previous discussion, would this surge in blood flow occur during systole or diastole? If you said diastole, you're correct. Once the baseline tracing is acquired, the cardiologist injects adenosine via the catheter at a dose that maximally dilates the coronary vessels. The adenosine-induced change in flow is taken as coronary flow reserve, and it's typically between 3 and 4. So here's a summary of the coronary circulation. We've discussed everything in here, so I think it will all make sense. Check it out when you get a moment. And that concludes Lecture 14. Thank you so much for your attention.